Hello, welcome, bienvenidos, welcome. Welcome everyone, bienvenidos. Hola, bienvenidos, welcome. Bienvenidos, welcome everyone. Bienvenidos, buenos días, buenas tardes, welcome. Welcome. Hola, buenos días, buenas tardes. Bienvenidos a todos. We'll get started in a few more seconds here. Bienvenidos, hola. Welcome. Hello, welcome, buenas tardes. Buenas tardes, welcome, welcome everyone. Buenos días, buenas tardes. Okay, we're gonna go ahead and we're gonna get started. So, hello everyone. In the name of the National Latino Behavioral Association, the National Hispanic and Latino Addiction and Prevention Technology Transfer Centers, we welcome you. My name is Ana Chavez Mancias. I am the Program Specialist for the National Hispanic and Latino ATTC. Welcome to the first session of a two-part series titled A Cultural Adaptation of a Screening, Brief Intervention, and Referral to Treatment. SBIRT, for working with Hispanic and Latinx communities. I will be your host for today's presentation. Next slide. Before we introduce our amazing presenter, here are some brief instructions about our event. Here is the information about our grant. You will receive a copy of this presentation so you can read the content at your own convenience. Next slide. This session will be recorded and archived for future playback. A copy of today's presentation will also be made available. The lines will be muted throughout the presentation to minimize background noise. When we get to the Q&A portion of our webinar, you will have an opportunity to ask questions by clicking the Q&A box, and we will share your questions to our presenter. We will also be asking you to fill out a brief survey at the end of this webinar. This satisfaction evaluation is important to the work we do and provides us with the opportunity to improve our training efforts. A certificate of completion will be sent via email at the end of the webinar. Closed captioning is available for this event. You need to activate your screen by clicking the live transcript button at the bottom of your screen, then choose Show Subtitles. Next slide. We'd like to take a moment and reflect on the power of words and remind you that together we can use our words to create positive change. Next slide. Here is the Ttc Network Map with information about the addiction, prevention, and mental health technology transfer centers. Each network is comprised of 10 regional centers and 3 national centers. The network coordinating offices, National American Indian and Alaska Native TTCs, and the National Hispanic and Latino TTCs. Our center has a national focus for Hispanic and Latino communities and the workforce that provide services to these communities. Next slide. Please allow us to introduce you to our parent organization, the National Latino Behavioral Health Association, NALBA. NALBA is a nonprofit and is located in New Mexico with the mission to influence national behavioral health policy, eliminate disparities in funding and access to services, and improve the quality of services and treatment outcomes for Latino populations. Next slide. NALBA's objective is to provide national leadership on mental health and substance abuse concerns of the Latino community. NALBA's policy priorities are selected capacity expansion of mental health services for Latinos, Latino behavioral health evidence-based practices, legislation to increase the number of behavioral health professionals, funding for co-occurring disorders of alcohol and substance abuse, opioid crisis in the Latino community, and suicide prevention. Next slide. We want to take this opportunity to invite you to the 2022 National Latino Behavioral Health Conference, Latino Behavioral Health Equity, Juntos Podemos, on September 15 and 16, 2022, at the Sahara Hotel in Las Vegas, Nevada. This conference will provide a forum for behavioral health professionals from different areas to connect, exchange ideas, and together explore best practices to attend the Hispanic and Latino communities. I will ask my colleagues to share the conference website linked in the chat so you can take a look and learn more about this incredible event we are organizing for our communities. Next slide. Our team is staffed by Dr. Susie Villalobos, serving as the project director for both centers. Priscilla Jamesi serves as the project coordinator for the National Hispanic and Latino PTTC. Cristina Mancibo Torres works as the program specialist for the PTTC, and I am the program specialist for the National Hispanic and Latino ATTC. Next slide. Now it is time to introduce our presenter. Diana Padilla is a research project manager at the New York State Psychiatric Institute, Division of Substance Use Disorders, Columbia University Medical Center. She is a curriculum developer and senior trainer for the Northeast and Caribbean Addiction and Prevention Technology Transfer Centers. Ms. Padilla is certified by the New York State Office of Addiction Services and Supports as an SBIRT trainer. She provides intensive technical assistance and implementation support to organizations in a variety of settings who are seeking to incorporate the SBIRT intervention practice to address health, psychosocial, and other concerns related to harmful levels of alcohol and other substance use. Next slide. Diana, thank you for your availability to share your knowledge and your experience with us. Please feel free to start your presentation.
Wonderful. Thank you so much, Anna, and thank you to the whole team for the support. And thanks everybody for being here. I am delighted to present on this topic. I have always had a major focus on culture. That's been the core of my work, but I'm also passionate about SBIRT, and it's nice to be able to kind of bring it together and share with you. And share with you what the innovations have been. And so next slide, please. And so before I really delve into the content, I wanted just to make sure that I share with you all that I have a tendency of using the terms Hispanic, Latinos, Latinas, Latinx. I use them interchangeably. And so I just wanted to explain that when I do that, even though I know the topic Hispanic, Latinx, I do that because I want to be inclusive and respectful of how different people identify. And I think that's just one of many ways where we can do that. And so I just want to respect all of you and how you identify as well. And so our goal for this two-part webinar is really to inform not just how SBIRT intervention can be culturally adapted, but also to understand why we're encouraged to do so. You know, and so that really means we should really take a look at what are the factors that are part of the challenges and that the Hispanic and Latinx people have been traditionally dealing with. So the current environment, and I'm thinking about how it's been for, you know, coming off the last 2.5 years, the current environment has really created a heightened state of survival for many in the Hispanic Latinx communities. And these are folks, and we're talking about our communities that have traditionally had to deal with a host of different challenges, but have been more exacerbated because of the COVID pandemic. And we're not clearly out of the woods yet. We are still dealing with the aftermath of it, and the environment, it's not necessarily stable for a lot of folks. And so Environmental conditions. It's important for us to kind of just get a read on what's going on out there so we can understand what's impacting our community members that we need to outreach to or provide services to. So it's important to kind of consider some of these different factors. So environmental conditions are those that are associated with health outcomes, especially when it comes to treatment of substance use or mental health or chronic pain or trauma. And so when we think about like well-being is really dependent on good health. And that's really impacted by the availability or the accessibility of really pretty basic resources like shelter, like income or income with living wages. And so next slide, please. And so that it's hard to kind of consider some of the disparities within the communities without having a conversation or really looking to what social determinants of health are for the Hispanic peoples. So social determinants of health. And I'm interested to see if you folks can kind of type into your chat box and you can say, and you can identify or define what you think social determinants of health are, if you've heard of it, because this is really should be, lately the conversation around disparities have really included SDOH or social determinants of health. And if you've heard of it, just type in there and just let us know that you have. Very good. Okay. So these tend, very good. So these tend to be, thank you for the responses. That's really great. These tend to be those areas, those social or ready, let me just say life domains that impact the person's development. So it has a lot to do with, where you grew up, where you went to school, maybe where you go to worship, where do you get your needs met? And so things like going to the doctor on an annual basis for a checkup, or being able to access like fresh fruits or vegetables. It's even the quality of the air we breathe, and depending on the community or the area or where we live and where we work. And so the safety of our neighborhoods and so much more. So the context of the community environment affects people's choices, their life choices. Folks are trying to live some type of quality of life. Many people are surviving, which is not, which for some folks that can be so challenging. So even on a daily basis, understanding how your environment can affect how you eat and what you eat, how often to exercise, how many community members, how many of the folks in the Hispanic and Latinx communities that we do provide services to don't necessarily have access to, say, healthy environments that encourage activity. Like, for instance, just having a park, a jungle gym in a park in your neighborhood. And that's not something that's commonly present amongst the different demographic areas or geographic areas rather, that Hispanic and Latino peoples actually live. And so when you think about that and think about how that environment affects a person's decision-making process, you got to consider all these other dynamics are going on. Whether it's a safe housing, where there are job opportunities, what are the language and air water situations, language and literacy skills, proficiency. Also got to consider maybe how racism and discrimination and violence may play a part. And so these are circumstances that are driven by or underscored by the, I'm not going to say distribution, I'm going to say misappropriation of funding. A lot of times it's lacking, and those resources are lacking. Needed resources are lacking in some areas. And so they end up resulting, like the social determinants of health end up resulting to be the very influences of a person's life. And it really speaks to their overall health. And when they do have health issues, or they do have other issues like substance use and mental health issues, where do they go for services? Where would they access resources? That's especially important. Next slide, please. So let's talk about, the health inequities, which is really what I'm leading to. And so health disparities, they're like the preventable gaps, because it is preventable, those gaps that exist, gaps in health outcomes that exist amongst a diverse group of folks. And for our population, for our purposes, we're talking about the Latinx populations. Health disparities experienced by groups based on their social, ethnic, and economic status refer to the differences in access to services to address mental health and substance misuse. And so the idea here, and it's really segueing off the social determinants of slide information, is like the different impacts, different things that are going on in a given person's world is the very things that's going to help influence whether or not they're going to seek help for that, or is that a priority for them, or do they see it as an issue to have to access a resource in the context of the fact that they have to go get a job, that they have to keep food on the table for the kids, and so much more. And so in terms of the Hispanic and Latinx community, the CDC suggests Hispanic health is often shaped by factors like language and cultural barriers, lack of access to preventive care, and lack of health insurance. And so we know also that poverty and ACE, or adverse childhood experiences, intergenerational trauma, and even intergenerational substance use are all social determinants of health and influenced by structural racism. And when I think about intergenerational substance use, I'm on the East Coast, and I could tell you that it's more common these days than ever before to actually see families in treatment, different families, like, you know, the parental families, even the older grandparent families, even with a person who's in treatment care. And so that's not unusual these days. So for the past 2.5 years, it's been tough for the Hispanic and Latino communities to deal with loss, with grief. And we know that because we've done it. We ourselves have had to deal with those very issues, trauma, and all of those factors and more tend to increase stress. And it's especially impactful for the Latinx community who were disproportionately affected by the COVID pandemic. And also economically and physically, and their emotional well-being. And so next slide, please. And so when we start to think about some of that, we also want to consider ourselves, how did it impact the communities? And so we do have differences in here. We should note that the Hispanic and Latinx terms that we tend to use, they're umbrella terms, but there are diverse communities that are kind of covered under these umbrella terms. So we did see differences in how long a particular family or a person has lived in the US. We've seen differences in acculturation levels. We've seen differences in ancestry. We see differences in culture and so much more. And so we also see differences in the heterogeneity of the Latinx communities in terms of substance use experiences. So here we have, you know, Puerto Ricans have, we take the distinction of different communities. Puerto Ricans have the highest rate of recent illicit drug use. And so that's almost 7%. It's not compared to South Americans who have the lowest, over 2%. We see Puerto Ricans have the highest rate of recent marijuana use, 5.6%, compared to Cubans or South Americans who seem to have the lowest at 2.1. And so of Hispanics, we see that they have the highest rate of recent cocaine use, while the Cuban community have the lowest. You know, the different noted differences in these communities, it indicates that Mexican Americans report higher rates of alcohol use disorder, whereas Puerto Ricans were more likely to report higher rates of illicit substance use. And so the point here is that we may have some umbrella terms, but they're very specific cultural issues, very specific dynamics that impact the different communities. And that also leads to different ways, different substances that are consumed and how they're consumed at what rates. And so it kind of speaks to the point that one approach is not necessarily going to fit everyone. It really underscores that comment. And so, and next slide, please. Right, so when we think about the socio-cultural factors that can influence, and thinking about things that would influence feelings and attitudes or the belief systems of the Hispanic and Latino community, it influences how they make decisions, what their behaviors. So Hispanics with substance use disorders, folks who do meet the criteria of substance use disorder, significantly underutilized treatment compared to the Black and white communities. And so disparities which persist even when controlling, these disparities exist even despite controlling for sociodemographics, insurance status, and so on. And so cultural factors such as so we're thinking about culture and language and even past experiences. Those influence and impact someone's ability or someone's decision to whether or not seek help. So the 2020 National Survey on Drug Use and Health reports that over 18% of people with Hispanic or Latinx backgrounds other factors that existed with them were co-occurring disorders. So they had also mental health diagnosis along with their substance use disorder, which certainly would impact someone's ability one way or another, and would definitely impact their decision on whether or not they should seek care, or whether or not they can seek care, or where they should seek care. So and then they were more likely than white community to be court mandated to treatment. And so now we're seeing the involvement with the criminal justice system that tends to happen in terms of as a segue into treatment, as opposed to a person deciding on their own. But the criminality or the criminal justice involvement, and not necessarily criminality, I'm going to say very specific criminal justice involvement, tends to be very present in Hispanic Latino communities. There's some other data. There's also like, so Latinx males tend to, those who have low income but tend to be employed full-time are more likely to be at risk, a higher risk for alcohol use disorders. And so when we start to get to know who our communities are, and we start to understand the specific details of what is common or what is going on in their world, it gives us a better idea. It should be able to help us inform our practices, how we engage, how we interact, how we may facilitate a particular intervention. How do we specifically meet individuals' needs? So people kind of, you also have to figure that socio-cultural factors are the things that also influence, in the context of their world and their environment. Also, folks respond differently to different circumstances. Next slide, please. So these are quotes that were captured within a study exploring structural, sociocultural, individual barriers to alcohol use treatment amongst Hispanic males. Good treatment is expensive. Okay treatment does not work. Free treatment is a nightmare.
I think that's some of the reasons why some men don't get treatment is because they simply can't. They fear because they are undocumented or they do not have insurance or it's too expensive. I'd imagine that there are programs that can help, but well, I do not know. I guess there is lack of information.
Yeah, thank you. These quotes are part of the study and they illustrate the perspectives and opinions of the folks they work with. Some of them are from the folks that actually responded, are part of the study, some of the folks who facilitated the study. And all having to do, these are some of the attitudes or perspectives that influences how someone or why someone may not access treatment. Next slide, please. And so when we think about, some of this might be more familiar to you, but and I get a little frustrated sometimes because part of my background is in research, and there is not a lot of consistent research when it comes to Hispanic Latino communities. Many times we have to kind of look at the individual studies and maybe even be informed by meta-analysis, that there are some consistent factors that have been identified throughout different research projects. So Hispanic Americans in the National Institute of Drug Abuse Clinical Trial Network, they did a research, and this one was very interesting because it spanned 2 decades. So that's 20 years of research. And so what they were able to identify in the 2020 review was they found that in the Hispanic community, many face several barriers. And these are not necessarily new, because a lot of this is just further confirming some of the things that we already know, especially some of us who have been working directly with these communities. And so some of the barriers that affect treatment include higher rates of unemployment. They're less likely to have insurance. And insurance is such an issue because a lot of times there are some organizations or some settings that will work with someone without insurance, but they have to be insurance or Medicaid eligible. And then there are some places that will not be able to do that. There are a lot of places if a person is court mandated, very often they're required to pay into it and pay into their own process as well. Then you have one of the biggest issues that came up also during the pandemic, and you folks will probably dealt with some of this or encountered this in some kind of way. A lot of folks don't have the access to internet that many people may assume that the average person has. It really depends. First of all, distance is a big issue, but the kind of service that you get on your phone and the kind of service that you're able to afford is certainly going to impact whether or not you have say internet and maybe the potential or the possibility to be able to access telemedicine or a teletreatment. You know, so there are some folks, some settings where when the pandemic started, you know, we started to use technology. We started doing video conferencing. Zoom never thought it was going to get off the ground the way it did. It just boomed. You know, so there are a lot of these different interventions, these different platforms were being used, but not everyone can access them. Many people with a phone had limited access to the internet. It's either free Wi-Fi, which was limited, as it tends to be limited, particularly in rural areas. And so that was a huge issue. That was a barrier to care. And so also long travel times to substance use disorder service locations. And I really feel like that has been such a consistent, that is one factor that's been so consistent, that travel times and the ability to get there and the time it takes when folks who do not have a car and have to take public transportation. There are some areas around the country where that if you don't get with the schedule, you can really, you can actually wait more than an hour and a half to even get the next bus. So these are really huge issues for a lot of folks. And then the other thing that we noticed in the study is that when Hispanics were able to access treatment, even when it was possible, what they found was, compared to the white community, there were less successful treatment outcomes. That to me indicates that it's possible to get through a program and go through however it's structured to the other side. It doesn't necessarily mean that they met their needs very specifically, and the outcomes were actually meeting their needs in a successful way. And so the treatment outcomes weren't as successful. There's a lot of lower satisfaction with treatment. This is not new. Also, we've been seeing this consistently in different survey data that we've that we reference. And so they're not very happy about how certain programming is kind of provided to them, how certain schedules and how certain interactions work with the providers themselves. And often, and this is not surprising for many of us, we do know that there are shorter stays in substance use disorder programs. So retention is key. It's really important, not just to engage someone, but be able to retain them in care. So I really believe that a lot of what we start doing is not just representative of what a person can expect, but how we initiate that rapport, how we engage them right from the beginning, is really going to be essential to how you continue to interact and work with them throughout their recovery process. And yes, and I see, and then there was the fear of using technophobia to be able to get to telehealth via different platforms. You know, a lot of people don't understand that it's not second nature. A lot of folks have to understand very specific details of how to use technology, where to use it. And that's even for folks who did have some data that they can use. And then after that, some folks were not able to keep that data because they weren't working, because they weren't able to pay those bills. So there's not to mention that there's a host of other issues. So next slide, please. So let me just bring it back to some of the variations. Really important about tailored care, or what we call person-centered care. And so there are variations of alcohol use in the community. And so I wanted to look at the patterns of alcohol consumption and the trends. And just like we saw, like the other slide where it reflected differing patterns of substance use and substances being used or being consumed. And there's also variations in alcohol use. And so in the Puerto Rican community, among men, they tend to drink more as compared to the Cuban population, which tend to actually consume alcohol least. Among women, Puerto Ricans tend to drink the most, and Mexican women the least. Now, the higher levels of drinking and binge drinking among Puerto Ricans and Mexican Americans compared with Cuban Americans and South and Central Americans were a lot higher than most people might even think about. And I think I would be remiss if I didn't mention that it's not like everybody drinks, but there are a lot of times is those who do tend to drink will drink more than the recommended guideline. And so about almost 25% of Latinos who reported binge drinking in the past month, according to SAMHSA. And so when I say binge drinking, this is a good time for me to ask you all. Put in the chat box, if you don't mind, how do you define binge drinking? Four more drinks for women, five for men, five for one. In one's more than 5 drinks in one sitting, drink different for men than women. Okay, so there's a couple of different, the comments I've responded to a couple of different variations of my questions. That's drinking to limit yourself, 3 or more drink. Okay, all right, great. That is awesome. Thank you for responding. So binge drinking is the way the National Institute on Alcohol Abuse and Alcoholism defines it. It has to do with one sitting. So yes, the recommended guidelines are no more than 3 drinks in a day for a woman, or no more, not to exceed 7 drinks in a week. A lot of times they frame it as 1 drink a day in a week, or no more than 4 drinks in a day for males, not to exceed 14 in a week. And they tend to, and a lot of times these days, it gets framed as no more than 2 drinks in a day. So binge drinking, and someone hit it on the nose right early on, was really specific, is drinking more than that within a short period of time. And so binge drinking really has to do with, say, drinking more than those guidelines, those recommended guidelines within 2 hours. And you can tell me, and you can put in the chat box if you know why we say that. How much time do you think we need, an average person needs, to be able to metabolize or process a drink, a standard drink? One hour. Thank you. I see that. One hour. And that's one standard drink. And we're going to talk about this more specifically in the next webinar. The idea here is there's a lot of, because of all the research that the NIAAA, National Institute on Alcohol Abuse and Alcoholism, that they have gathered, and this is how they make the recommendations for what is an appropriate level of drinking between male bodies and female bodies. And so they've also noted that if you drink more than 1 standard drink in an hour, when you start to drink like 2 or more, there's certain things happen. Your blood alcohol level goes past the 0.08, which is like, that's the framework that, that's actually the guideline that indicates that you are, that you're over the drinking recommendation. You're drinking over the recommended guidelines. But when you have more than 1 drink, you don't have your body doesn't have time to process that ethanol, that alcohol in your body. And so what happens is you tend to, your body tends to respond to that level of ethanol in your system. But you as a person can also respond and start to feel all those symptomatic issues, the slurring of speech, that word escapes me, being able to just, being able to be coherent. And, you know, folks tend to be impaired at that point. The thing is, there's differences between males and females, and it has a lot to do with how much water is in the body, which is needed to process ethanol. And the average male body tends to have more water in it to process ethanol than the average female body. And so, and there's more information on that, and we'll send that to you. But the idea here is, because that reflects the differences in recommendations. But the idea here is to understand that going over the recommended guidelines is what's considered binge drinking. And now in the Hispanic and Latinx community, we don't necessarily see a lot of, for folks who don't meet the alcohol use disorder, there's a lot of folks who do binge drink. And that's the idea. And so if it takes over an hour to metabolize 1 drink, you know, it really has to do with, you know, what are the people's habits? What are their behaviors? And how often, just how often have you provided services to anyone in the community, or just think about your world when you're just socializing, and how common is it for the average person to know what the standard recommended drinking guidelines are? That's not your normal conversation. That's not the conversation we typically have with anyone. So these are guidelines that are not even necessarily informed. They're not necessarily forming the communities in the first place. And so we know, because we work in behavioral health, we work in treatment settings, we work in prevention and recovery supports, we work in all these community-based organizations, that this is more important for us because it's part of the work we do. A lot of people in our society don't. Hispanic and Latino communities don't necessarily get this information. Next slide, please. And so what I wanted to show you here. So this is pretty telling. So this was a ready-made image, and I wanted to use it here because when I facilitate screening, brief intervention, referral, treatment type trainings, I tend to use it because it's such a good visual to kind of just get you to, like, in a snap, just kind of understand just how prevalent the issue of heavy alcohol use or binge drinking or at-risk levels of consumption of substances really is. And so on the left, what you see is these 4 little figures, and that represents the communities that do meet the criteria of substance use disorder. Now, in any given year, we do treat folks with substance use disorders anywhere between 2 and 2.5 million people a year. There are still more than 20 million people out there who do meet the criteria on any given year, but we're admitting, and we're treating folks at that small 10% level. But for every person that has a substance use disorder, that includes alcohol use disorder, you have, it used to say here, it used to be like every person, there was at least 4 people who would be consuming at risky levels. Today, what I do know about the Hispanic Latino community is that for every 10 people that drink alcohol, 9 people binge drink. And when we think about it, what are some of the health outcomes that can come from binge drinking? If you think about it, it's not just the neurological impacts and the impairments, the cognitive impairments. It's also about how, if these habits are indulged in quite frequently, how can this affect a person's well-being? How do we understand? Yes, and there's alcohol poisoning too, and we have no predictors for that. I am not familiar with any research right now that indicates this person is likely to be suffer from alcohol poisoning than this other person. There's no predictors for that. The idea here is to understand that consuming at certain unhealthy levels has an impact on an individual's lives, particularly if they indulge in it and do that more frequently. And so there's loss of work. Loss of work influences high rates of consumption. Different social-cultural factors that have been exacerbated by the pandemic, and how that has been created an environment that had increased stress. And how do a lot of folks cope with that? They may go to substances, and a lot of folks went to alcohol. When the pandemic hit in February 2020, by May 2020, we saw that across the nation, alcohol purchases, increased by 55%. It was a way to cope and deal with these stressors and things that folks were not familiar with. And so when we think about 9 out of 10 people who binge drink, who don't meet the alcohol use disorder, we're looking at a big, large community that we don't always address, that we don't always provide services to. And that's especially important with our communities because we do see binge drinking here. And that's especially important. And so, next slide, please. And so let's think about this. Care really must reflect understanding and values of diverse communities. Out of the top 3 contribution factors that contribute to disparities, and someone mentioned it, is about having that disconnect with a provider. Language has been identified as a potential issues, but a person's culture and how you engage someone and how you speak to them makes a big difference as well. And so when we're working with Hispanic Latino communities, we want to think about the importance of using or offering personalized care. That's culturally sensitive care that respects patients' beliefs, preferred language, communication needs, and which is really what we're talking about when we mention culturally responsive services. That's especially important because I know we always talk about cultural competency, but I want you to be familiar with the term culturally responsive because it's very specific to what we do, how we engage the community, and which is really our responsibility. And so when we are responsive, we're respectful and integrating beliefs, practices, and cultural and linguistic needs of that individual. And when I say respectful, I don't mean not just not being rude. I mean you literally acknowledge, recognize, and integrate cultural perspectives and practice, because that's going to affect the likelihood of higher or successful outcomes. And then you also, ultimately, when the equity goal includes to be more culturally responsive, it also means that the organization itself is addressing the dynamics between power relationships. Many times, and you folks can tell me, many times we are asked, persons or professionals who are providing direct services to community members, many times, that is the person that is required to be culturally informed. That is the person that has to do the cultural competency training. That is the person that has to be very effective in any type of cross-cultural situation with community members, particularly Hispanic and Latinx folks. And so what we're talking about here with culturally responsive services, we're also encouraging that organizations can also be culturally responsive. And so there's this opportunity to address these power dynamics in different levels of operations and protocols. And so to be able to have these cultural philosophies, not just with frontline staff or those who directly connect with the communities, but also in operations and protocols and governance. And so the idea here is to create an environment, that can be supportive, not just of the communities we serve, but also the staff themselves. Think of it this way. It's a way of being culturally and linguistically appropriate, which I'm going to go through now, but it's not an add-on. So many times organizations want to advance equity with Hispanic Latino community, and they want to add this component very similarly to how they get funded for a program, and they roll out that program. They're getting funded by this other initiative. That's another service that they provide. And this other program gets funded, and that's another service, and they roll it out. Culturally and linguistically appropriate services are not an add-on like that. In order to be culturally and linguistically appropriate, what you want to do is use the lens by where you will facilitate all these service deliveries through. So it's not an add-on. It's something that you incorporate in that lens. Through that lens, all those different programs and services are provided. That is how we enhance our equity with these communities. Next slide, please. So some folks have heard of the culturally and linguistically, the National Enhanced Culturally and Linguistically Appropriate Services. If you've heard of it, just put yes in the chat box. If you haven't, just put no. So see, I'm not surprised. I mean, there are some folks that are saying yes, and this is a lot more than I used to get a year ago, but many people haven't heard of it. So let me just tell you what happened. Let me tell you where these come from. Thank you, everyone. So the Nationally Enhanced Culturally and Linguistically Appropriate Services Standards were developed by the Office of Minority Health, which is a part of the Department of Health and Human Services. Decades ago, we saw disparities within racial and ethnic communities. And so as a response to that, and we saw we saw several reports, but there are two very glaring reports that really highlighted these disparities. And that was back then. And so as a response to that, the Office of Minority Health developed these 15 actionable steps, which are really the linguistically and appropriate services standards. And so with these standards, what they were able to do is help organizations understand what would that strategy look like if an organization wanted to be more equitable, wanted to be more culturally responsive with Hispanic and Latinos, wanted to other racial and ethnic groups. And so what would that entail? If you think about it, in the last 2.5 years, many agencies, many organizations, many settings are so adamant about trying to evolve their services and be more tailored and more responsive. And a lot of folks don't know how. And the energy is there. They're adamant about their desire to advance equity, but they don't know how. the class standards is a way to do that. It provides a blueprint, it provides potential steps, 15 actionable steps that organizations can consider integrating and implementing. And that can result collectively, it can result in that supportive atmosphere, and services will be more culturally informed, and communities' needs will be addressed more specifically. So what it entails, it has this one principal standard, and this is kind of a mouthful, but this principal standard is about providing effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, their preferred languages, the health literacy, and other communication needs. And why is that important? When I was just speaking about culturally responsive services, which is what is all the research and many of yours experiences and other expert experiences, we've seen that is more of what we need with Hispanic Latino communities to help bridge those gaps and those disparities, to help access care, to help for us to be able to outreach to them and to be able to connect and help them, achieve that wellness process, that wellness pathway from their cultural perspective. And so this principal standard is really speaking to what organizations can very well be doing. Doesn't mean that you're not doing, but this process involves a way to enhance the current, what your current infrastructure is doing. And so what we can do is also look at about the other 14 standards, which are in 3 categories. Theme 1 is about governance, leadership, and workforce. And so this is what I mean about it not being an add-on. Culturally informed practice is not an add-on. And so thinking about culturally and linguistically appropriate services, then thinking about how that philosophy can be integrated on different levels of operations and different protocols and governance, and the approaches that, and the concepts that are used to be able to process out and to roll out these programs to the communities. So in order for everyone to kind of have culture in the forefront and understand about this individualizing of service delivery, so the class standards suggest that policies and procedures can be infused and enhanced with class standards. And we're thinking that also that diversity amongst all professional levels is especially important. The challenge is not just to have frontline staff that represent the community. Representation is essential wherever possible. It's really important. That is a very engaging opportunity for Hispanic and Latinos and Latinx members. But it's also important to have that representation in other levels of operations. And so when we think about leadership and executive leadership and board members, we suggest with the class standards that there should be representation there as well. That helps to increase the likelihood that the class will be a lens as opposed to add on. And so that informs the different initiatives that at these level of work, these level of professionals work within. Also, the suggesting that annually culturally informed trainings shouldn't be just for frontline staff or the people who need to keep their credentials and licenses. I work with an organization not too long ago, and one of the things I asked one of the board members was, when was the last time they had attended a cultural competency training since being on the board? And they had admitted to not ever going. So that is not necessary. So what that speaks to is not necessarily being part of the thinking and the conversation in terms of, working with an organization and how they respond to community needs and what grants or funding opportunities to access, to follow through on, to taste. So if everyone is more culturally infused in their thinking, they're more collectively supportive of these services being more tailored to community members. And that's only one part, because a lot of opportunities or blueprints that do exist for organizations to advance equity are not necessarily looking at the governance part of how a particular agency or organization works. So this is important to understand, that it should not be just certain folks, it should be throughout the organization. And the other thing is, language has always been key. And a couple of you folks did put it in the chat box. Language is really important, isn't it? When you think about the Hispanic and Latino communities, we're thinking about language. But it's language Language is just one dialect. It's just one form of communication. So there are times where the community members who come in, you might automatically be the person that a person who speaks mostly Spanish may be the one to be connected to you because you're the one who speaks Spanish or you represent the community. And guess what? What happens? Communication is more than that. Sometimes you have to know, is it the right dialect? Is comprehension there? What is the cultural context of any conversation with any given individual? So it's language and communication. So in order to understand that, so the standards are really speaking to inform and provide language assistance services. Many times the people in our communities are not aware that they're entitled to language assistance services at no cost to them. And a lot of times, unless you tell them, they won't know. If they go to the doctor, they go to somewhere else, and then they come back and share it with you, they may have challenges or may be frustrated. They don't understand what's being said. And then we'd be the one that would have to tell them, did you ask for language assistance? Did they even offer it? So I want to bring the question back to us. Are we offering it? Are we automatically saying, listen, if we need language, what is your preferred language? And are we offering it? Because we're not always doing that. When I was doing direct services, we were told we were supposed to do treatment plans or service plans in their language. But I was still told to do it in English and translate it for them verbally. It's not the same thing. And then I didn't always have the same Spanish. So really, to be specific here, language assisted service is something that we as providers, we have to ask about. What is your preferred language? Let's not make any assumptions, even if they seem to speak English well. Let's just provide as just part of the routine, a part of the standard of care. We should ask what is the preferred language and note it. Because if you're not there one day and someone else has to pick up and work with that person, that patient or that client, then it's important for them to know that should be documented. So what do language assistance services look like in your area? What are the interpreter services that are available? We also have organizations that do provide them, but perhaps some providers have not used them in a while. Do they get annual trainings on how these services are accessed and how to use them? Our interpreters, are they informed about the dynamics, the 45 CFRs, the HIPAA and confidentiality laws that apply to your setting? How are we using those services? And sometimes even language conducive materials. We don't know the literature, the research literature that we tend to give out that supports the different information that we share with our patients and clients. They should be in their language. How do we know which is the appropriate dialect? And that's a question for you all. How do we know what is the most appropriate language or dialect to use, or any particular language of a community? How do we know that? You can put that in the chat box. Okay, we can ask each person. What if the person answers you, but can't answer you because they don't speak your language? By talking to the folks in the community, check for understanding. So here, this is really different. So this is really specific. So asking each person, asking the client. So the way we ask is through assessments. So the principal standard here, if you're gonna involve anyone, if you're going to provide these services, you have to know who's in your community. So we do ask them, we do assess your communities and your community, the demographics in your community. Back in the day, it used to take 3 to 5 years. And that's what the researchers used to tell us. And they used to say it takes 3 to 5 years before, that was the time frame where demographics would change in any given community. Well, that's not so and hasn't been so for a long time. So on an annual basis, we should be checking to see who are our folks and are we still providing services that are meeting their needs? Do we need to tweak them a little bit? Do we need to update them somehow, enhance them in a different way? We want to know if our services are meeting their needs. Are they in the appropriate language? Are we able to understand what that is? So from a programmatic perspective, you have your potential next steps in how to engage and how to assess for the community. As an individual provider, you also want to consider, are you using the same language as them? Is there comprehension? Are we using some core communication skills to check in on their understanding? And I'm going to cover some of that more specifically in the next webinar. And so when organizations can kind of go through these these different standards, you also want to check that when an agency is committed to making change, you want to check to see that the strategies that you as a team are implementing are working. And if they're not working well, how can we change a little bit just to make sure that we're having the effective outcomes that we want? So the class standards is a blueprint. It's a whole set of strategies that any agency can look at, and you don't have to brainstorm how to advance equity. All you have to do is, okay, look at these potential areas, look within your organization, do your own assessment, look at all the things that you're doing great. And then look at the things that are looking at the service delivery of certain areas of the organization where it can use some improvement. Perhaps conceptually, you can apply, some of the strategies that are working in one area and apply them in others, but look to see, what's working, what's not working, and understand who the communities that they should be working for. And so the class standards from an organizational perspective and an individual provider perspective can be so insightful. So you don't have to brainstorm from scratch, and you folks don't have to get together and just, how are we going to do this? How are we going to advance? We want to be appropriate. You know what? Follow something that has worked. There's a lot of information on the Office of Minority Health website, and there are a lot of examples of efficacy with organizations that have implemented these standards. So we are going to talk about how some of this applies in what we do as individuals, and particularly when it comes to cultural adaptations of an evidence-based practice. Next slide, please. So linguistic and cultural disconnects.
The problem is that if the clinician does not understand the cultural aspects, well, they are going to focus only on the education that they have received. Maybe a lot of the things they do will not help, although some things might. Sometimes language is a barrier. Not everybody speaks perfect English. Most of these programs are in English.
Thank you, Anna. And you know what? A lot of you folks are putting in the comments, a lot that relates to what this slide is about. That's why I wanted to bring it up now. There are differences in when you do speak Spanish, and there are differences when you get to know who is in your community. And there's also different levels of literacy in terms of comprehension from the side of the provider. So you want to be mindful and prepare for those type of interactions. Because what's our ethical responsibility? To be clear and transparent with patients and clients that we work with. And so in order to do that, we need to be mindful and at least aware what are the potential communication nuances or dialects that we need to integrate in our work environment in order to meet their needs. And this is something that we shouldn't be doing as in hindsight, as a result of any situation. We want to avoid that. We want to be able to prepare, and the class standards give you an opportunity to just tell you a couple of things, like assess who your community is. When's the last time we looked at that? And then find out what are the common elements that they deal with, that they are likely to present with, and what are the communication or the language needs. And that right there can just kind of start to inform certain things that you're doing. So next slide, please. So when we're thinking about communication barriers, and many of you have mentioned this, yeah, and I appreciate that, Christina, that you mentioned, some Spanish words mean one thing, and I can say the same Spanish words. I'm pretty fortunate that I was raised in a family where I was taught how to read, write, and speak English and Spanish. Rather in Spanish first, and then English, and so, but when we do that, we also have to know that there is a whole context behind words. Words I say may mean something completely different for you. It's the same thing in English, except with Spanish, depending on the dialect and because of the culture, there's so much more that that is associated with any particular word. So context is really important. And so, Latinx people report difficulties finding services that are available in Spanish. Not surprising there. There is very few across the nation. There are, compared to the amount of treatment facilities and even recovery and prevention support resources that we have in the communities, there's a very small percentage that are done in the Spanish language. Doesn't mean that folks don't know how to speak English, but the comprehension part is so important that maybe Spanish is the best way to be able to communicate with them. And when we're talking about potentially behavior modification, this is very, very important, particularly because there's so many nuances within the Hispanic culture. So that adds to, why also to the fact that because there are a lot of few and in between services that are done in Spanish, it also kind of speaks to why there's a long wait for those that are available. And imagine how many people get frustrated waiting a long time to access the service. It's hard enough to access the service and to actually get to a point where you may need services, whether it's a doctor or hospital or whatever. But if you're far away and you don't even speak my language, I may think about using some home remedies, but I probably won't see you. So, because then I know there's going to be long waits. If I'm going to wait that long, I'm going to get frustrated. I'm going to try the different means to address whatever issue I'm going through. And that's not unusual, uncommon with a lot of Hispanic and Latinos. And so nearly 6 in 10 Hispanic adults have had a difficult time communicating with a healthcare provider because of language or cultural barrier. So here we understand that it's not just the language. Now we start to understand that there's also the context, the cultural context, different words meaning different things. The conversation itself is very relevant to what different words are mean and how they're used. And so, in the next presentation, we'll talk about how we have certain approaches to be able to actually do that. But think about all the complexities that different people, Hispanic and Latinos, come with, and then they're trying to speak and share with you, their situations or how they perceive a particular situation. So next slide, please. And here I want to just speak to this, uninteractive dialogue.
When I tell them I don't understand them, they'll bring someone over to speak to me in Spanish, and I don't understand them either. We didn't grow up speaking that formal Spanish, so I have no idea what they are saying.
This is really, thank you. And this really speaks to those language assistance services that we can access. When you have someone who speaks Spanish, but it's their own form of Spanish. And folks, and there are so many different dialects, but there's also many regionally. You have cultural idioms that are influenced by the area where someone lives. And that's influenced by the experiences where they live. And so when we're thinking about, idioms, and thank you, the accents I want to speak to that in a minute. Those all have to do with communication. And if you have an individual who's going to get frustrated, it's kind of hard to keep their receptivity. It's kind of hard to keep them retained if they go through that a lot. So what is it that we can do? And so I wanted to share some perspectives. So next slide, please. So there's some perspectives, and we got this right from the community themselves, members from the Latino and Latinx communities. And so speaking about communication, and there was they call the battle of managing language barriers. And so trying to speak and understand using English because that's what the provider is using, and someone just mentioned it here in the chat box, speaking in English, and perhaps you have a heavy accent, but thinking that you're being perceived or someone acting as if you're less than intelligent because you have a heavy accent and they can't understand you. There's a lot of communication dynamics that happen between two people. But when these other factors are present, it can exacerbate the frustration on both sides, but the potential on the outcome with the patient or the client is extremely important to consider. So preference for bilingual providers is key, but I'm going to suggest not just bilingual, but also bicultural. So it's not enough just to speak Spanish. If possible, folks who are familiar with different cultural groups. So if you have a Mexican American community or you have a Chicano community in your area, you also have some South American, you have folks from Guatemala, you have a nice cluster of folks who live in your community, who are in the community and within your catchment area. See, this is why, again, this speaks to the importance of assessment. So you want to understand the dialect differences and want to understand what you can and can't use, because you also don't want to offend anyone, and you certainly want to, if you can't engage, and at least you attempt, you have to be able to recognize that there are differences, but you also have to be recognizable, cognizant of the fact that different perspectives is part of what they'll bring to the conversation. So being bilingual is great. Being bicultural is even better, you know, and that doesn't take a lot, being familiar. It really starts by being aware of who's in your community. So there are times where negative bias toward interpreted encounters where, very similar to what I presented before, where someone, you know, they use an interpreter, but they have a hard time understanding them. And supposedly they're both speaking Spanish. Or the interpreter, perhaps, it's not even that. The interpreter might be using a language, but the interpreter, let me say this in a kind way. As Hispanic and Latinx people and Latino people, people tend to be more approachable in how they engage with one another. And they're more receptive to that type of dialogue that is based within that type of atmosphere. And if an interpreter is just kind of just blankly just giving you those words and the correct idiom for that patient or that client, but everything else is missing, that can be very frustrating for that person you're trying to provide services to. So the cultural context, again, becomes very important. There are folks that do get by. They know just enough English to get by and have their needs met within the immediate environment and where they live or where they work. And they don't necessarily have to understand more than maybe some words. And if we encounter folks like that, when you want to provide services, you really have to be mindful and understanding, you know, just how you can use language assistance services to be able to provide information on how substance use works. Say someone is coming in for substance use. Let's not even talk about substance use. Someone consuming at a risky level. How do we have that dialogue? How do we have that conversation with them? And which is part of how SBIRT works. How do we have that conversation when there's only certain words that they understand, and you can only say certain words. So actually having someone to be able to mitigate within that is really, really important. Clarity is key. Comprehension is something we seek, and we do have opportunities. We do have opportunities to be able to ensure that comprehension is there. And so there's fear of being a burden, and a lot of folks don't want to give you a hassle, you know, just because they need services. And that has to do with some of the values in the community. And stigma and discrimination, you know, past experiences with this certainly impacts whether someone is willing to, you know, try that communication with the service they're seeking. Next one, please. So in terms of stigma, substance use in Hispanic culture, we understand that there's misunderstanding to linguistic and cultural disconnects. But stigma includes those stereotypes about people who use substance use, who have substance use disorders or use substances. And that very much can alienate people who are from the Latinx or Hispanic communities, particularly if they adhere to values like personalism or simpatía. Personalism is about respectful engagement, but it's also about how someone is perceived and how you engage with someone. And if you're acting in a way like you're judging them, that kind of connects with that personalism. So your approachability is really essential. Simpatía is about congeniality in a sense, and it's about kind of not making waves. So having discussions sometimes, you know, that is part of someone's own identity and their value system. And shame is a big deal in the community. So vergüenza, which is really Spanish for shame, it's important to understand that these factors can be present within different levels or different degrees, and that can be part of the communication. So we need to consider how, you know, having had past experiences where, you know, stigma has impacted folks is really important. Self-stigma, there's 3 types. Self-stigma is how a person characterizes their negative feelings about oneself and start feeling discomfort or uncomfortable about themselves because people treat them in a certain way, and start to feel uncomfortable with the idea that they are from Hispanic or Latino culture. Social stigma is how folks are stereotyped and are being stigmatized, like the lack of resources or the resources that are available are compromised or deficient. And you also have structural stigma, which is the negative attitudes and behavior of those who represent larger groups. Next slide, please. So here we have a polling question. Anna? Please choose which one you think is the most appropriate describing evidence-based practice. Just pick one and just submit. Okay, I guess we can close it and let's see what we have. That's a really good response, folks. You folks are so way ahead of me here. Evidence-based practice, the most appropriate response is the practice that results from the best research evidence with clinical expertise and includes patient values. That is so key. The others are maybe elements, but not necessarily for how we define evidence-based practice. And I see the responses in the chat box. You were right, both of you. So next slide. So just to kind of round this off, just to bring this to a close, evidence-based practice, next slide, please. Evidence-based practices and culture, there you go, or EBPs, are the integration of the best available research with clinical expertise. And it has the patient characteristics and culture and preferences. That should be included. So the purpose is to promote effective psychological practice or enhance public health by applying what is usually empirically researched, and principles that are incorporated, whether it's for psychological assessment, case formulation, interventions and such. Next slide. And so evidence-based interventions, and which is really what we're going to be speaking to, is that are not originally developed for underserved populations often need to be adapted. And that's part of the reason why we're here. And that's why we provided you all this context to get to this point. Cultural adaptation process includes attention to many dimensions of culture. And so this speaks to why we identify certain interventions that we culturally adapt more than others. And so how closely to the cultural dimensions or cultural characteristics of the community is the intervention that we are looking to adapt. And so they have, interventions tend to have a strong empirical base, and they can maintain and even enhance effectiveness throughout different cultural adaptations. Next slide. So when evidence-based interventions are unacceptable, there's often a discrepancy in terms of efficacy, of course, because it's not meeting, it's not aligned with the cultural characteristics of any given group. What we want to do is understand that cultural adaptations refer to the type of systematic modification of a practice. Or in our case, we're going to be speaking to an evidence-based intervention. And the model we'll speak to more specifically in a few. It's really one that can incorporate language, culture in the context in such a way that is compatible with clients' culture patterns, meaning, and values. Next slide. And so the one thing that we have to keep in mind is that in order for an evidence-based practice or intervention to still be an evidence-based practice, even after cultural adaptation, is that we have to keep the fidelity. And so when we consider, adapting a particular EBI, what we want to do is understand what are the core components and how we keep that part of it within the structure of the intervention or the practice, and we still make it culturally informed, but we do it in a way where the core components are not compromised in any way, so efficacy can still be expected. And so we use the ecological validity framework. It's for cultural adaptation that speaks to dimensions that we can incorporate when we are working to adapt a particular culture. And so the next slide. So this is what the process can look like, and we're going to show you more specifically with an actual intervention. But really what you want to talk about is understand, again, assessment, understand who's your community members. Can't just say, just the Chicano community. If we have South Americans, if we have folks from the Dominican Republic, if we have folks from all different places, we have to understand who are the folks that we're targeting or adapting the intervention for. Understand, and then kind of see where does it correlate the potential intervention to adapt does it have the components to correlate with those cultural characteristics and determine what the modifications will be. Next slide. Cultural normalization.
Well, it's in our lifestyle, for example. If you're a young man, you see it, right? You see that your father drinks excessively. Uncles, you understand? All of the people that surround you.
Thank you, Anna. And so this cultural normalization is what we want to link to with the SBIRT intervention. Next slide, please. So here's the thing. Screening, brief intervention, referral treatment, or what we often refer to as SBIRT, is an evidence-based model that includes a person-centered approach. When you're person-centered, if you have a process involved, then you are more likely to be more tailored to that individual. And that has a lot of potential, a cultural appropriate potential for Hispanic and Latinx community members. So SBIRT can work well with many groups, but consistent with screening and culturally competent care is not often practiced. But we're going to show you how SBIRT can certainly help mitigate those gaps. And really, it's not a long stretch. This is not a complicated process, but it's one that's very essential for working with Hispanic and Latinx persons. And I think that's where I'm at. And so we will give you a lot more information how that's going to segue into what that SBIRT adaptation, that cultural adaptation of SBIRT can be on the next presentation. I thank you everyone for staying here and for engaging with us.
Next slide, please. Present this contact information. If we were not able to answer all your questions, please do not hesitate to reach out to us or to our presenter, Diana Padilla, who was kind enough to share her contact information with us. Next slide. Please take 5 minutes of your time to complete the survey. Your opinion is very important to us, and we would really, really, truly appreciate it. Next slide. Again, please visit our conference website to learn more about all of these amazing things we're preparing for you. This conference is taking place in September 15 and 16 in Las Vegas, Nevada. We invite you to join our second session next Wednesday, August the 10th at 2:30 Eastern Standard Time, so we can continue this conversation with Diana. Please share this link with your family, friends, and contacts so they can join us as well. We would also like to share with you our contact information. Please feel free to connect with us in case you have questions or if you need any assistance. Thank you and have a lovely week. And we can have some questions. We have some time for questions with Diana Padilla.
So the link was provided for the evaluation. The host, it was just entered in the chat box. Please click on that. It doesn't take more than a couple of minutes to fill out. And that makes it easier for us to be, for the team to be able to confirm that you've been here and they can send you your CEs. Any questions or any commentary from what we've covered so far in this first part? I'd be more than happy to take a few questions now. So please type it in. So, okay, if you don't have any outstanding questions or comments or something comes to you, it's okay. You can also bring it up at our next session. I really, really do appreciate your participation and everything that you all do, that you're interested in how to reach our Hispanic and Latino communities a lot more specifically. There's such opportunity here, really is. And this is not going to be too complicated for you folks. So I'd strongly encourage you to come back for the next session. It's been really wonderful. Your participation has made this amazing. Thank you all.
Diana, we do have a question in the Q&A.
Okay.
Maybe I missed it, but what is the
Oh.
difference in scoring when using SBIRT that is culturally adapted versus one that is a standard? Latinx people get more drinks?
No, not at all. There is, the scoring is not different. We're not going to culturally adapt the scoring itself. The instrument, the screening instrument, and we'll cover this, is going to be, has to be a validated instrument. And so the opportunity is more about how you frame that process, but the scoring is very specific to those questions that you're going to ask. And that scoring is going to justify whether or not to have that conversation, that brief intervention. So that's going to be extremely important. But in that conversation, that brief intervention dialogue, that's where those specific details of the person's drinking, their consuming of alcohol, and all of the related issues is where it's going to come out. So stay tuned. I'll give you more information on that when we come back.
And there is another question in the chat, Diane. Why is it that the Cuban population has the lowest level of alcohol consumption?
Well, I think some of the, there's no one specific response to that, but I will tell you that some of the things that the data shows is that in the Cuban community has a higher propensity for access to resources. And so the risk and the stressors are not as predominant in that community as they are with other Hispanic Latinx community. You know, when the Cuban community started to come over here back in the days from, you know, when they were leaving Cuba, they were coming in with wealth. And wealth is one of the protective factors and that also puts you in position to access resources. So that starts to be one of the mitigating factors that speaks to why drinking is less. I mean, drinking when it's not from stress and trauma and other challenges in your life. So that kind of is less in that community.
And we have one more question in the Q&A. It says, I'd be interested in seeing videos of culturally adapted SBIRT practice. Are there any available that you're aware of?
So here's what I'll do. How about, Jennifer, how about if I take that as homework and bring it back, and then we'll be able to share with you in the chat box and everyone else. So let me see what might be there. There are a lot of times what happens is individual communities will adapt their own. So I do have one or two that I work with other organizations to create, but it's not like readily available nationally. But there's a couple of them that I may be able to share with you, and I'll bring that. So I have homework. Thanks, Jennifer, for the question. I like that. All right.
Looks like there may possibly be another question in the Q&A.
And that was a comment. Thank you, Cheryl. Can we share the Gipper link one more time? Awesome.
Thank you very much. This is a very important link. This evaluation helps us continue to provide the services and these wonderful informational learning environments and webinars such as today. So please take a moment by either scanning the QR code or using the link, which also I believe was shared in your chat.
So this has been a treat for me, and I appreciate every single one of you. Thank you for taking the time to be here, but really to also add your information and your questions and your comments, because that is what makes any of these presentations that much more robust and relevant to you all. So thank you all for that.
Thank you all. Gracias. Thank you for coming. We'll see you next week.